the videos. So without further ado, research to practice, optimizing cancer care updates for 2020 with Benyam Muluneh, PharmD, BCOP, CPP. Dr. Muluneh, welcome. Glad to have you here today.
Happy to be here.
So let's see what we have some bio information. Let's see if we've got this right. PharmD, BCOP, CPP received your Doctor of Pharmacy at the UNC Eshelman School of Pharmacy. I believe that's the top pharmacy school in the country. And completed PGY1 pharmacy practice and PGY2 hematology oncology residencies at the UNC Medical Center. So far, so good?
Yep.
Okay. After residency, practiced full-time as a clinical pharmacist practitioner, where you and your team established pharmacist-led oral chemotherapy program, which was designated with an ASHP Best Practice Award in 2015. Since you've co-authored the 2018 Hematology Oncology Pharmacist Association Best Practices for the Management of Oral Oncologic Therapy. Joined the DPET in 2019 as an integral member of PharmD curriculum by progressing the teaching mission of the school. Scholarship interests include adherence to oral oncolytics and precision dosing in hematology oncology patients in an effort to improve outcomes, and also a passion for international health, and serves as a preceptor for one of the global pharmacy scholar experiences to Ethiopia. And additionally involved with as a clinical pharmacist practitioner at the UNC Medical Center's Leukemia Clinic. So that's quite a list of achievements. What's one thing that wasn't on there, maybe a little more personal, that you can tell us about yourself?
Today is my birthday.
Oh my gosh, happy birthday. Well, so I should go ahead and unmute everyone so we can sing now, right?
No, that's fine. You can skip that part.
Okay. Dr. Muluneh, we're so glad to have you here today. Thank you so much. I've got, I mentioned poll everywhere. Our first question, we always try to make this kind of a softball. Financial toxicity describes problems in a cancer patient has related to the cost of treatment. And just let us know if you think that's true or false. I'll put that up in just a moment. And while we're thinking about that, this activity has been planned and implemented under the sole supervision of the course directors in association with the UNC Office of Continuing Professional Development. William Wood, MD, MPH, and CPD staff have no relevant financial relationships with commercial interests as defined by the ACCME. Benyam Muluneh, PharmD, BCOP, CPP has no financial relationships with commercial interests as defined by the ACCME. All right, let's take a look at that poll everywhere question. Our audience should now be able to respond to that. Financial toxicity describes problems a cancer patient has related to the cost of treatment. A is true, B is false. Dr. Muluneh, how are they doing?
I think they're doing very well.
Great. All right, so with that, optimizing cancer care, updates for 2020. Practice challenges and solutions. And I'll turn things over to you, and you just let me know when you're ready to go to the next slide.
All right, you can go ahead. I have no disclosures, as Tim mentioned. And the objectives are to identify key practice-related barriers to optimal patient outcomes in oncology, to differentiate patient-level and system-level challenges to delivering cancer care, and to describe best practices to enhance patient engagement, medication access, and treatment adherence. And I'm very excited to be with all of you. Feel free, as was mentioned earlier, to please ask your questions along the way, and I'll try my best to answer them either during the talk or after. All right, so when I agreed to do this talk last year in 2019, it was not yet 2020, and that we didn't have the coronavirus pandemic, and we didn't have several other challenges that we've had thus far. And so the closer it got time to this talk, the more nervous I began to get, in realizing that there are so many things that have changed, right? The way we deliver cancer care has changed significantly. And so I've had to continually change the kind of the focus of the talk. So I'll try my best to contextualize everything we're talking about in everything that's going on in the world today. So the first thing, obviously, that we're all dealing with and aware of is the coronavirus pandemic, right? And there's a lot that we can say about the impact of the COVID on cancer patients, and how, the fact that cancer patients they are immunosuppressed, and they already have a lot of complications. And so then you add the challenges of COVID, that obviously is going to lead to even more challenges for our patients. But this analysis that was published in JAMA earlier this summer actually showed one kind of really concerning statistic, which was about the new incidence of cancer has actually decreased across many different cancer subtypes, which basically indicates that patients are not getting timely screenings, patients are not going to the doctor when they're having symptoms, and so that is leading to potential delays in diagnosis, which means that in 2021 and 2022, we may actually be seeing higher grade cancers being diagnosed, which is a real concern, so something that we will be talking about today. The other thing that we have always, we have obviously been seeing for such a long time, but it has been heightened in 2020, is obviously social justice issues. And we know that disparities in cancer care, are things that have been around for a while, and we know about the history of medicine in this country. But there's, I would say, an increase in heightened awareness to do something about it. We need to have more solutions for address disparities in the United States. And I was very excited when I saw this report by the American Association for Cancer in the AACR's inaugural report for cancer care disparities. So, and this is really important, and when I say I was excited to see this, I'm not saying I was excited for the disparities, right? The disparities are alarming, but it's great that we at least are able to put some numbers, right? So, Black men have a prostate cancer death rate that's more than twice that of white men. Hispanic children are 20% more likely to develop leukemia than non-Hispanic white children. Men living in the poorest U.S. counties have colorectal cancer death rate that is 35% higher than that for men living in most affluent U.S. counties. That bisexual women are 70% more likely to be diagnosed with cancer than heterosexual women. These are all numbers now that we know of, that's out there, and for researchers and clinicians, these are targets that we have to improve. So again, another kind of really important issue that has permeated every sector is this idea of the social justice, healthcare equity. So these are also kind of topics that we're going to be touching on throughout the talk. All right, so we have now a pandemic, right, that seems to be getting worse, unfortunately. We have these healthcare disparities that we're more aware of, certainly not new, but we also have ongoing practice challenges in oncology, such as lack of patient engagement and non-adherence, which I will be talking about, and that's kind of an interest area of mine, as well as financial toxicity, which is sort of an interest of many policymakers and clinicians and healthcare practitioners, and it's an emerging area of research as well. So when we look at, we have lack of engagement and non-adherence, so we will look at that through the lens of the pandemic challenges, right? And knowing that now a lot of the care that we're offering has been transitioned to telehealth and virtual care. So just thinking about how can that maybe help, so serve as an opportunity, but how might that also hurt how we engage with patients, right? So how are virtual care services being implemented, and what is the impact that it has on patient care as well as on clinician well-being? All right, and then same thing with financial toxicity. We'll talk a lot about financial toxicity, but what are the challenges of kind of navigating the complex system of medication assistance services when you don't have access to directly being with the patient to gather signatures, for example. And then, of course, we know that there is unemployment. Although things are improving, there are still a lot of patients who have lost their jobs and they've lost their insurance coverage. And what does that do to the system? And how does that kind of worsen financial toxicity. All right, so we're going to jump right into talking about adherence. Now, I will talk a lot about adherence, but it's not really just focused on medication adherence. So when you hear adherence, also think broadly about engagement, treatment engagement, and how patients are engaged with their own healthcare, right? But I have as a pharmacist, a particular interest in adherence, and we know that adherence is the single most important modifiable factor that compromises treatment outcome. And it continues to be something that is a problem and a gap that we all must try to address in our patient care practice, especially in today's world. All right, so when we think about adherence specifically to self-administered therapy, such as oral chemotherapy drugs, we know that there are a lot of benefits, right? These drugs tend to be beneficial, convenient to patients. Patients feel empowered when they are able to, get away from the infusion clinic and are able to kind of move their treatment to their own homes. That's really empowering. Patients like that. There are a lot of survey studies that indicate as such. There's potentially decreased toxicity and increased efficacy. But obviously the concern is adherence. And how do we get patients to understand the importance of taking their meds? What are those barriers that get in the way of patients taking their meds? And what are kind of storage and handling considerations and therapy monitoring concerns? And so we're going to focus on some of these areas today. So the first thing we need to do is define what we mean by adherence. And in general, engagement, as I said, is kind of a larger umbrella if you want to think about engagement to, for example, going to doctor's visits and getting screening done and so on and so forth. So adherence, the definition is the extent to which a patient's behavior coincides with medical advice. And there are obviously significant consequences. You all know, right? Poor outcomes, increased toxicity from, for example, over-adherence. There's some data in the literature that suggests that some patients, when they get really nervous about what their cancer is, if they're progressing or having other sort of adverse outcomes, they might take more of their drugs. Patients may not have the right kind of educational background, and they may misunderstand instructions. And so increased toxicity is certainly a consequence, as well as increased healthcare costs. So when we look at non-adherence broadly in chronic diseases, we know that there are some specific factors, right? Some specific numbers to be aware of. For example, we should know that how frequently someone takes their medication impacts adherence. So when patients take their medicines once per day, for example, the average rates of adherence are about 80%. Whereas when patients are asked to take a medicine 4 times per day, the adherence drops to 50%, right? So just in thinking about, the types of medication regimens that we're designing for patients, if you're starting someone on a 4 times a day medicine, just realize that that inherently is associated with a high rate of non-adherence. And then the second thing for you to be aware of is, especially if you're in a center where you're enrolling a lot of patients for clinical trials, that there's a high rate of non-adherence associated in clinical trials as well. I will say in oncology, that tends to be better, so we tend to be on the higher end. But some reports have published that, as high as 60% of patients may skip doses in clinical trials. And then, so this paper is from about a decade ago, where it was about $100 billion per year in healthcare costs due to non-adherence. But that estimate has now doubled to almost 200 billion. And just keeping in mind that adherence does tend to decrease over time, and so it tends to be higher in acute diseases, whereas is higher in chronic disease or worsens in chronic diseases. And as we begin to do transition cancer care to more like chronic disease management, where patients have to take a pill for the rest of their lives, that means that adherence is probably going to get worse over time. And we've shown this in our own work, where we showed that patients who are on treatment greater than 12 months tend to be less adherent than those who are on treatment less than 12 months. So this is just a study that actually compared IV drug, an IV drug fluorouracil, to oral capecitabine. And oral capecitabine is just an IV form of that drug. And what actually happened is we expected the two drugs, the IV and the oral, to do similarly, but the study from CALGB 60104 found that the oral drug, even though it's just an oral formulation of the IV drug, it tended to do a lot worse. And when they actually looked at adherence for the oral therapy, they found that 22% of patients had a less than 90% adherence rate. And so that is what they kind of hypothesized, that that's actually probably what led to the poor outcomes they saw with the oral agent in the clinical trial. And when looking at consequences, in clinical practice, so I mentioned, in the introduction, you heard I practiced in the leukemia clinic. And, in chronic myeloid leukemia, we often talk about how a lot of the treatments that we have really revolutionized and the outcomes of these diseases, especially chronic myeloid leukemia. And life expectancy, if patients are adherent, is as the same as their age-matched counterparts, which is really amazing when you think about the fact that this disease used to be, uniformly fatal when patients were diagnosed with it in the 80s. However, you can see from this chart that, on the y-axis, we have the probability of MMR, which is sort of the gold standard for CML treatment. And then in the x-axis, you see time since start of imatinib therapy. And what you see in the blue is that if patients are adherent greater than 90% of the time, their likelihood of achieving this gold standard is above 90%, whereas patients who are adherent 90% or less, that's missing more than 2 doses per month, their rates of achieving this gold standard is less than 20%. And a lot of folks who know my practice style know that whenever patients get diagnosed with CML, I print out this article and I show patients, and patients understand. I will tell them, if you are missing more than 2 doses per month, you are in the yellow. And that is, obviously associated with poor survival. And so just being able to show the patients not just that they need to take their drugs, but why and what is the extent of benefit of taking their drugs on a daily basis. And so when we think about, I kind of been hinting at this, and we're going to dive into this, but this was the age-old question, right, of why don't patients take their drugs? It's been something, since Hippocrates has talked about it, right? Like, it's something that we've been trying to understand, and I really like this framework by the World Health Organization that kind of outlined the main dimensions of adherence. And oftentimes, we tend to really understand the patient-related factors, but we may not always understand or appreciate other factors such as therapy-related, socioeconomic, health system, and condition-related factors, which I'm going to be kind of diving into. But I believe we have a question first using poll everywhere.
We do. So which of the following statements is false? And A, if you're using the text, would be African American men have a prostate cancer death rate twice that for white men. And again, we're looking for the false answer. B, cancer patients can face loss of employment and insurance coverage. C, a patient's ability to adhere to therapy can diminish due to increased healthcare costs. Or D, the greater the frequency of prescription administration per day, the greater the adherence. So A, B, C, or D. If you take just about 6 or 7 more seconds, and thank you so much to all of those who have already answered this. All right, Dr. Muluneh, we have a pretty strong trend going. How are they doing?
Very good, very good. More is not more, right?
Mm-hmm.
More is not more. And we're going to talk a lot about, obviously, I talked about that data, but this also is related to, polypharmacy, and the number of medications also impacts adherence. So we'll talk more about that. So thank you all for your participation. Great. All right. So now we're going to talk a little bit more about the different dimensions from using the WHO framework, right? So when we think about the health system factors that might impact adherence or engagement in general, these are things outside of the patient, right? So we're talking about poorly developed health services. And one clear example is medication distribution systems, right? We know that those of you who work with cancer patients, to get a patient specialty medicine, you have to send a prescription to a specialty pharmacy. That pharmacy may not be in network, so you have to change it to a different pharmacy. We have very complex insurance systems, and then the drugs have to be shipped to the patient. It's a very, here in the US, we have a very, very complex and poorly set up distribution system. So we have to sort of think about the systems and workflows we have in place and how do those things benefit the patient? How are they patient-centered, right? And there's an emerging science called implementation science that actually can help different cancer centers in terms of developing services that are actually evidence-based, especially when we're thinking about virtual care and telehealth. Thinking about, how do we think about virtual care in the context of patients who are living in rural areas? How do we think about it in patients who may not be technologically savvy or may have poor literacy? I am a pharmacist. I am, educated, but, recently I had to get my daughter to do this virtual visit with her pediatrician. And it was, I thought, it's relatively complex. And I was thinking about a lot of my patients who have to navigate this system. And one book that I actually, for those who may be interested, that I would like to recommend, I don't know if you guys can see it on the screen, but it's called Planning Health Promotion Programs. Planning Health Promotion Programs. I can send out more information. I promise I didn't write it, or I don't get any royalties from it, but it's very good because it actually goes through and describes for various types of services we want to implement, what are those theoretical frameworks that we can kind of take advantage of, and how do we kind of translate those interventions into clinical practice while keeping the patient in mind. So just keeping this factor in mind when we're designing any sort of services that impact the patient. Socioeconomic factors usually tend to make a lot of sense to us, especially how they might impact adherence or engagement. But more the next step of research, what's happening now, especially with what we talked about, understanding and having a heightened awareness to disparities in care, is not just saying, okay, illiteracy is going to impact adherence, or low level of education or unemployment is going to impact non-adherence, but what do we do about that? So what is the systematic approach behind patients who are cognitively, may have cognitive impairment? So, I think one thing that a lot of cancer centers across the country are talking about is how do we set up services that are equitable? Right? So if I am setting up some sort of patient education program, how do I make sure that those patient education programs are going to be translatable to patients who may speak English as a second language, who may not be able to read, who may be incarcerated, right? So thinking about our patients who are not just those patients who are who have the ability to access, can read and write, and have high educational backgrounds, but all our patients who may have these specific barriers as well. And of course, you see that, for example, transportation has always been a barrier, but maybe now, if we are able to set up equitable virtual care platforms, maybe those things can also help kind of mitigate some of these socioeconomic barriers that our patients might face. And of course, condition, the patient's actual condition can actually serve as a barrier to getting the care that they need. And the first bullet point you see is the severity of symptoms. So sometimes patients might have severe symptoms and they, may not feel like taking their drugs because they just feel bad. We're actually doing a survey study now trying to, disentangle this relationship between symptoms and quality of life and adherence, because it's believed that if patients take their drug, then that's going to help them feel better, and it's going to going to help them get rid of their cancer. But is the opposite true? Is it that when patients actually feel better, are they more likely to take their drugs? So our study team now is trying to disentangle this bidirectional relationship between symptoms and adherence and how those change over time. But when we say severity, it's not just, patients having terrible symptoms that might impact their adherence. It also speaks to having no symptoms, right? There are times where we incidentally discover cancer. There are times where we're trying to encourage patients to get screening for their cancer, right? We know, for example, colorectal cancer screening is really suboptimal, especially in our Black patient population, who tends to have a significant amount of mistrust to the healthcare system, and with good reason, given the history of medicine practice in this country. And so how do we engage with different populations to increase screening, right? The U.S. Preventative Task Force recently came out with recommendations dropping the age of screening for colorectal cancer patients. But how do we implement these evidence-based recommendations to our patients? So those are all questions we're still trying to ask, but just keeping in mind that the condition itself and helping patients to understand, you may feel better now, but what are the consequences of how you might feel, not necessarily how long you might live, but how you might feel if you are not getting the care that you need and deserve. A level of disability, rate of progression, sometimes that patients who might have relapsed or progressed, they might have a little bit less motivation, right? So just thinking about the condition factors that actually might impact adherence is an area of active research. The therapy, this is of huge interest to me. The complexity of the medical regimen, I already sort of hinted at this, that the more medicines you take, the more times you're asking patients to take it, the more complicated it is. It's gonna lead to higher likelihood that the patient will not adhere to the regimen, right? The duration of therapy, has the patient treatment, failed prior treatment, as I mentioned. Are there frequent changes being made, right? Sometimes I see new studies coming out, especially in the area and leukemia, and maybe the benefit is really marginal in terms of survival benefit or in terms of actually making patients live longer. But then the treatment regimen might be highly complex compared to the status quo, but we're so eager because we want to kind of implement the latest drug, the latest and novel approach. We tend to jump onto the new thing, right? But is that new thing actually benefiting patients, or is it going to actually cause them to be less adherent, maybe cause more side effects without real substantial benefit to patients in outcomes that they care about, like living longer, like feeling better and spending time with their families? And then there are lots and lots of patient factors, right? And these are things that we, again, understand, but the thing I'll talk about with the patient factors is that you're not going to be able to assess. You're not going to be able to give surveys. So if you talk to a lot of researchers, they'll say, well, there are a lot of validated surveys to assess forgetfulness, to assess, cognition, mistrust, and low motivation. But we know in clinical practice that's not feasible. But what I usually tell clinicians is that it's really important to realize in that first visit to establish trust, to establish, do the education about the treatment, and mainly get at these patient-associated barriers at the second or subsequent visits. Because if you're trying to identify potential barriers, the patient may not even know. They may think that they're not going to forget to take their meds, but they're not going to know until they're sort of into the treatment. And so a lot of times I don't really spend a whole lot of time talking about trying to figure out if the patient is very motivated or, are they likely to be forgetful, unless those concerns come up. But I like to do follow-up like 2-3 weeks after they start treatment. Then I really like to find out how it's going and what are the different patient-related factors that might be impacting their adherence. Sometimes it might not be related to what's going on. It might be the pandemic is too stressful. It might be that they don't even trust the fact that they have this cancer. I've had that before. And so how do we build that trust? It's something we should all be thinking about throughout our interactions with patients. So I'm just going to briefly share our experience here at UNC in trying to better understand patient barriers to adherence. This is a survey study trying to understand why patients don't take their meds from the patients themselves. Next slide. So we included adult patients who are English speaking, who had a variety of different malignancies from here at UNC, who are taking one oral antineoplastic therapy. And we adapted a survey that was used in primary care setting, which asked questions based on a Likert scale. And again, we focused on patients' understanding of how to take their medicines, their sources of information, ease of understanding the drug biolabel, and perceived importance of food-drug effects for drugs that had an interaction with food. Next slide. So we approached 95 patients, and we were able to enroll 98% of those patients. Next slide. And this was the demographics. So so we had about half were women, less than 6 months therapy, half the patients were on therapy less than 6 months. 58% of patients were older than 50, and this was actually a well-educated group with 68% of patients having completed some college. And you can see the distribution of patients who are on therapy everywhere from less than 1 year to greater than 5 years. Next slide. So these were our notable findings. So 44% of patients did not think about the last time they ate, even though they were taking a medicine that had a food-drug interaction. And 14% actually mentioned that they take it the exact opposite way that they were supposed to. A third of patients sometimes forget to take their oral chemotherapy, and keep in mind that in oncology, we really are trying to aim for that 90% mark, right? 90% of doses need to be taken or more. So 30% forget to take their oral chemotherapy, and 21% actually mentioned that they sometimes cut back deliberately because of a variety of different reasons, including toxicities. And from those patients who mentioned or admitted that they were non-adherent, 38% mentioned that they don't tell their physician when they cut back, right? Next slide. And so the total kind of summary of our findings, there's confusion and misunderstanding about the timing of drugs with food. There's forgetfulness in oral antineoplastic administration. Patients are reducing and stopping their drugs without informing their physicians. And there's difficulty in understanding the directions on the drug biolabel. And that piece I didn't actually talk about. But I believe we have a question now, audience response question.
We do. So which of the following factors is likely to increase a patient's likelihood to adhere to treatment? So which one will increase patients' likelihood to adhere to treatment? A, low level of education. B, lack of effective support network. C, frequent changes in treatment. Or D, ability to understand directions on a drug label. So if everyone would take 6 or 7 more seconds, A, B, C, or D, if you're using the text method. And again, Dr. Muluneh, we've got a trend going here. How are they doing?
A+.
Awesome. Awesome. We have a sharp audience always.
All right. Yes. So of course, that is one thing that is very important, and we actually found out from our study that the drug label is highly underutilized. So just thinking about how we communicate about drugs and drug instructions is something I'm going to be covering next. Next. All right. So these are some strategies for management. Next. All right. So this is sort of like the cycle of therapy, right? So the patient gets diagnosed, goes to the clinic. There's a process for shared decision-making to start on a specific type of treatment. Then we have to worry about here in the US, especially access to care. Really, this is an issue obviously elsewhere in the world as well, but in the US, I'm always amazed by how much of an issue this is. And then will they take it? Or are there barriers that we don't know about that impacts their ability to engage with their care? And again, keeping all of these steps in mind, it can't just stop, right? When the patient leaves our clinic, it can't just stop there. There are a lot of steps along the way that we have to keep in mind. And then of course, keeping this in mind throughout their transitions of care, whether they're being admitted to the hospital or not. Next. So as far as assessing adherence, one thing that I always tell clinicians is the importance of keeping in mind that the way we're asking about adherence impacts the answer that we're going to get, right? So if you're asking patients, hey, are you still taking your medicine? They're going to probably say yes, because they're generally taking it. I mean, they may have missed like 3 doses, the past week, but they're generally taking it, right? So we should really try to elicit responses. And so the questions that we use should be validated whenever possible. So, and again, I recognize there are not a lot of great questionnaires out there that are validated that are also feasible for the clinical practice. But the one that I like and recommend is the Wilson's Medication Adherence Scale. This has been validated and through lots of studies, psychometric analyses, but mainly in the HIV and AIDS population. So it asks questions about in the last 30 days, how many doses were missed. It asks about how often did you take your drug the way you were supposed to, and then how good of a job did you do the way you were supposed to. And there's actually a way to kind of give a composite score, and then you are able to assess how the patient is doing. And so this is, again, a validated way to assess adherence. Next slide. This is a one question item that we use at UNC that has been, I'll say, semi-validated using medication refill data, but additional work does need to be done. But I do like it because it's one item. So since the last time we saw you, about how many doses of your drug do you think you may have missed? So this sort of makes it's not penalizing the patient. So in fact, sometimes I'll say before this, I know it's really hard to take your medicine every day and you have a lot of stressors, but how many doses do you think you may have missed? And making it so that, I'm expecting you to have missed some doses. It's okay. So again, that's sort of this type of questioning increases the disclosure by patients. Next question. The other way, and usually, I think that at least 2 ways of assessing adherence is ideal. So you can ask patients how they're taking their drugs, but you can also look at their refill history, right? So if you have students, if you have volunteers in your cancer clinic, this is something that you can ask them to do. So to call a patient's pharmacy, ask them to send you their refill history for the past 3 to 6 months, and you can actually we find this proportion of days covered calculator. It's found online, and then you can actually plug in, an Excel, for example, and you can find out what their proportion of days covered, or PDC, or an old term you might see is medication possession ratio. And, for example, in this above example, the PDC is 93.5, 93.75%, and you want the patient's PDC to be above 90%. So, it's kind of a nice objective measure that when it starts getting below 90% consistently, you start getting concerned and you may want to think about some interventions to help improve the patient's adherence. Next slide. Again, these are some helpful hints, but again, as I mentioned earlier, we shouldn't just throw all these hints at the patient, right? Say, let's do an alarm clock, and let's do, early management, and let's refer you a medication assistance counselor. We have to find out what are their barriers and be able to kind of link our solutions to their specific barriers that they have identified. Of course, again, it's our responsibility to ask the right types of questions, but again, and I don't usually focus on barriers unless these barriers are related to initiation of therapy, but for implementation and persistence to therapy, I usually focus on this, after they've started their treatment. Okay, so for example, if they have forgetfulness comes up, I do talk to them about setting up an alarm, but I don't just say you should set an alarm. I sit with them and I will actually ask them, let's take out your phone, let's put in an alarm. If they say, oh, I have a family member that might be able to help, I might ask the patient, let's call that family member. Let's get them engaged into their care. So thinking about our solutions, not just the solutions themselves, but the implementation plan around those, and being part of that plan, being part of the execution is going to be more likely to be effective. Next slide. We can also make patients' calendars. Sometimes when things get really complicated, there's just nothing out there that's going to make it easy. So I like to make patients' calendars. You can see that, I make some things underlined, some things italicized, some things bolded to just let, so that things can pop out. And then I'll ask patients every day, make sure you mark off after you're done with each day, mark it off to let yourself know and to let me know that you've completed that day. And if there are issues, if you got nauseous, write it in there in the side, like I got nauseous, skip the dose. And then so, they bring this back and it's a great way to facilitate communication and create a better follow-up plan for the patient. Next slide. And there are also a lot of electronic, adherence monitoring programs and other apps that help track patient symptoms. All right, so this is just a list from a study that actually did an analysis for the engagement, functionality, aesthetics, and information of these drugs, these applications, and found these programs. I can tell you that under the basic apps, MyMed Manager is really good, and there's a clinician portal, medactionplan.com, and a patient app that goes along with it. So it can be really nice, really nice, because when you're changing their medicine list on the Med Action Plan, it actually kind of changes their medicine list on their MyMed Manager. But one of my kind of hesitation to fully utilize and leverage these programs is the fact that they're still not fully integrated into the EHR. So that's one thing that a lot of folks are working on now, is how do we integrate these patient portals and these electronic systems into the healthcare record. And a second point, though, is because sometimes we have this like healthcare technology is kind of its own bucket, and then we have clinicians over here. There's a huge kind of gap. How do we ensure that once they are integrated, that they're actually, able to be utilized properly, right? If you have all these kind of information, patient information coming at you all the time, it could really be overwhelming, right? So how do we properly utilize these kind of programs? It's still something that we're trying to find the answer to. Next slide. So in clinic visits, patient really should be encouraged to voice their preferences. They shouldn't walk away feeling like questions were not answered. They should, be encouraged to write down questions and answers. So maybe in the clinic visits, do we have pens, pencils, notepads, things like that to kind of facilitate the patient's engagement. Next slide. And if you have a new patient binder or a new patient checklist that you provide to patients, maybe giving them like some of these questions that they can ask their physician or their other providers. Why do I need this drug? How long will I stay on it? So on and so forth. Next question. And so as far as patient education, I sort of already talked about this. A couple of new things I'll note is as far as management, adverse event management and tracking systems, I really like cancer.net. It is developed by the American Society of Clinical Oncology, or ASCO, and they actually have, clinician vetted, evidence-based, and patient-friendly information that's actually very good. So, our patients are going to go online. We might as well encourage them to use apps like this that are actually vetted and really free from, harmful information that can actually get in the way, right? And then American Cancer Society, cancer.org, actually has a lot of great resources as well. That's more paper-based toxicity tracking systems and so on and so forth. That can be really, really helpful. And then for patients who are taking drugs that actually interact with food, coming up with specific plan for the patient. So I really like it when patients leave the clinic knowing how their new drug is going to be part of their lives, right? How do we integrate that drug into part of their life? And when they can imagine that, okay, they're going to wake up at 6:45, they're going to take their Lapatinib, they're going to make the coffee, they have to wait an hour before they eat, and they're going to eat their breakfast, and then within 30 minutes they have to take their capecitabine. They have a high likelihood of kind of engaging and adhering to therapy if they feel like they can do it, that self-efficacy is ensured before they leave your clinic. Next slide. All right, so I don't have a lot of time to talk about financial toxicity, and I know there was an excellent talk last week, but I'm going to go through these slides relatively quickly. Next slide. Obviously, financial toxicity is a significant barrier to adherence, and a lot of having insurance does not necessarily eliminate financial distress or disparities. Next slide. A lot of patients have financial toxicity. They may not talk about it. It leads to missing appointments. It leads to non-adherence, but it also means patients are choosing between, whether or not they pay their bills, whether or not they're going to be able to eat 3 times a day or a healthy meal, so on and so forth. So financial toxicity as a whole is not just talking about the drug cost, right? It's talking about everything. Cancer care is very expensive and it has tremendous impacts on patients. Next slide. And a lot of patients, when they're surveyed, they don't talk about it because they feel like talking about their cost will compromise their care. And they also feel like it's not their doctor's job. And sometimes we feel like it's not our job because we're not trained, right, to always provide financial relief to our patients. And they also might be embarrassed, which is something that we see on a regular basis. Next slide. Why is financial toxicity important? Meaning talking about it and addressing it, right? Again, like we said, cancer treatment is expensive and it's getting more and more expensive. So we have to be able to address it in a multidisciplinary fashion. Next slide. Healthcare systems are also confusing. There are a lot of times patients are asked if they have insurance without specifying, is it the medical insurance, or is it the pharmacy insurance? And helping patients to understand some of these things. So having maybe a one-page handout on insurance would be great for your patients. As soon as they come through the door, they need to know if they don't have pharmacy insurance, they're not going to be able to get their drugs. And a lot of times patients think that they've moved through the healthcare system not needing medications. They come to me and they have to learn that, oh, they actually don't have Medicare Part D, so they can't get the drugs that they thought that they would get. Next slide. Language that we use, copay, deductible, drug formulary, specialty tier, these are all things I often tell patients, for them to understand. The more that they understand and feel empowered, the more questions that they can ask and get the help that they need. Next question. Again, cost of cancer care is expensive, $5,000 to $8,000 per year on average per patient, although we know that this can be much higher depending on the patient or their cancer type. Next. And other consequences, missing work, being able to get transportation, paying for parking, all of these things, in addition to the actual treatment, can actually contribute to financial toxicity as well. Next slide. And next. We know, for example, that nearly half of cancer patients have lost income or said it was harder to get by. These are data from 5 years ago, so just listen to these numbers, thinking about where we are now and the economic issues we're facing. Next slide. And a third reported using all or most of their savings. Next slide. 1 in 4 went into debt. Next slide. 1 in 5 skipped payment on bills or utilities. Next slide. And then 1 in 50 filed for bankruptcy. So again, if these were challenges that were identified in the past 5 to 10 years, just realize that these are challenges our patients are facing now, even if they don't talk about it, and that these issues are probably a lot worse now. Next. All right, so what can we do to reduce financial burden? This is just a mnemonic that basically is all about empowering patients to ask questions. We should also, as clinicians, ask patients about their ability, but the more we empower patients, the better it will be. So calling insurance representative and talking about the treatment plan and associated costs, asking about financial assistance programs that they may be eligible for, requesting to meet with a financial navigator, social worker. Are there less expensive treatments? Like I talked about earlier, the newer treatment is not always the best one for that patient, right? So just keeping that in mind. Next. You can actually go to the next slide. And then one campaign that I really like is the Choosing Wisely campaign. Choosing Wisely aims to promote conversations that enable patients to choose care that is supported by evidence, not duplicative, free from harm, and truly necessary. So if you don't know about it, go to choosingwisely.org. And this campaign works with lots of professional societies to make recommendations really aimed at stopping things. So do not use this drug in this condition. Do not test for these labs because it's not needed, right? So a lot of things that we do out of habit or out of culture that now are not evidence-based and could reduce costs for patients. So as a healthcare system, really engaging with Choosing Wisely recommendations can be really helpful. Next slide. These are additional resources, Patient Access Network Foundation and others. Again, we can provide these slides. Next slide. Again, for food, utilities, gas, peer support buddies, we have lots of different resources. Sometimes it's just being able to connect the patient with those resources. And it might just be as easy as going online. So there are meal service programs, transportation programs, childcare programs available. Not always and not everywhere, but there are at least some things that we can try to connect the patients with whenever we have the ability to do so. And these are things, you may feel like, hey, I don't have the time and ability, but maybe, volunteers, we've tried a volunteer-based program here at UNC. Volunteers and navigators can be excellent at providing some of these cares. These programs. Next slide. Talking to your pharmacist, I can't emphasize, I've got to say that involving the pharmacist is very important. There are lots of ways the pharmacist can get involved, not only to help with patient education and management of symptoms, but also potentially to connect patients with ways to help with the cost of their treatment. Next slide. Again, this is just a graphic that sort of that talks about, when a prescription drug is too expensive, what are steps that I go through. So just the take-home point here is patients are uninsured or have Medicare Part D. They need to get direct assistance from the manufacturer, or they may need to seek out grants, whereas patients with commercial insurance can actually get direct copay cards from the drugs manufacturer. Again, we can give these kind of more informational slides. Next slide. We can just finish up with this question. These are just additional tips, but we can finish up with the question.
All right. So which one of the following strategies for management is not effective? So which of these not effective? A, American Society of Clinical asking patients about their ability to adhere to a regimen. B, obtain records of the patient's medication refills. C, let patients worry about their ability to pay for medications. Or D, working with family members to set up solutions to barriers. So which of these four, A, B, C, or D, is not effective? And we'll wait about 5 more seconds. All right, Dr. Muluneh, how are they doing?
Very good.
Good, good. All right. And now we'll go ahead and open it up to questions through Poll Everywhere. So I'll be looking at those, and we'll go ahead and take those once they come in. So if you would go ahead and submit your questions. I love the notion, Dr. Muluneh, that you mentioned earlier of leading with those open-ended questions instead of have you been adhering to your medication, saying how many doses have you missed? That seems really powerful. Let me ask a question. For those patients who are maybe experiencing side effects, experiencing toxicity, have you found any ways that are particularly helpful to help them feel candid in sharing those concerns, as opposed to just decreasing or stopping medication without notifying you?
Yeah, and I think that's an excellent question. I think upfront letting patients know that there are going to be side effects, but we can manage them is really helpful to let them know that when you have side effects, we can talk about them. And the earlier we intervene, the higher likelihood that those side effects can be dealt with better. So there are data to support that. So I do think that asking about side effects preemptively, and even actually, like, if there are some side effects that are common, even telling patients not just about the side effects, but what are some self-management strategies to take care of those side effects is something that I have found to be really effective. So if the patients, in my experience, feel like they have that trusting relationship, they're going to be a lot more open to discussing these, versus if they feel like they're going to let you down, you're going to be disappointed that they're experiencing these challenges, they're less likely to mention them.
That's really helpful. And I always wonder how, to what extent patients become invested in the success of their healthcare practitioners, and how that can be problematic.
Absolutely.
We do have a question. I'm sorry it's not popping up correctly, but do you have one particular site to go to for financial assistance for all oral oncology drugs? And thank you to our audience member for that question.
That's an excellent question. If I had to pick one, I would probably select needymeds.org. I really like needymeds.org because it does have a sort of a centralized place that has manufacturer assistance, so drug manufacturer assistance programs, as well as third-party foundations like HealthWell and Good Days and things like that. So it's all in there. And so a lot of times when I'm trying to figure out if something is, if there's an assistance option for the patient, that's where I tend to go. And then it also has like links in there, so it kind of takes you to other sites after that. So it's kind of a nice first step, EDMeds.
Great. Thank you so much. And we have another one. A lot of African American men feel like skipping prostate test. How do you help educate them the importance of getting checked out and explaining the importance of being checked?
That's a really great question. I think a lot of times knowing the why is really important, and it may not be the same for everybody, right? So there are patients who may know of family members who have had challenges with the healthcare system, and that may be why they're mistrusting, or they might have other sort of preconceived notions, right? Why they might not be interested. So I really like, I don't like to give like one answer for this. It's really like doing that motivational interviewing and figuring out what are the specific barriers, and then connecting the benefits also, like, right, why it would be helpful for them. Specifically, like, for example, do they have a grandchild they want to see graduate? Do they have, thinking about those kind of benefits for them and trying to connect it with that. Do they know somebody that's gotten tested? Things like that. So I think less than like the data and the statistics, it's more of these other factors that tend to be more helpful. Again, I know I shared that book earlier. Another book that I would recommend is this Wiley Handbook of Healthcare Treatment Engagement. It's really, really good, that I highly recommend for healthcare systems to look at. It has both kind of theoretical as well as clinical practice recommendations on getting patients to engage to treatment. And it has like questionnaires and ways to approach these types of difficult conversations.
Great. Dr. Muluneh, thank you so much. And we can send out information to our participants about those in a day or two. We'll get that out. Let's see, one more, probably we're about out of time, so I'd say maybe one more question. Do you see a role for home infusion in some types of therapies such as checkpoint inhibitors?
I think that's an excellent question. I really believe that anything that any intervention we come up with that's patient-centered and that can be safely applied, I'm open-minded to. But I would say that anything we do has to be vetted in a properly conducted, implementation-based approach, and it has to be studied. So is it effective? So giving it in an infusion clinic versus in a home, what are the patient-related challenges? What are the financial challenges? I have certainly, we've used a lot of home infusion for other drugs before. There are lots of benefits to the patient. There are also lots of challenges. So I would just say before implementing something like that, just thinking about a plan to evaluate and monitor the success of such interventions. But I know some people will say we should never do it, but I'm open-minded as long as we're evaluating it in the context of a study, an implementation-based study.
Great. Thank you so much. And thank you to our audience for all of those questions. We also want to say thank you to the North Carolina General Assembly for their generous support of the University Cancer Research Fund. And we want to thank the UNC Lineberger Comprehensive Cancer Center. We want to thank our team, Mary King, Veneranda Obore, John Powell, and Anita Woodyard, for all of the work that they do for each and every one of these lectures. So thank you to them.